Hello, I'm glad to be here today, and I'd like to thank Boris Chaumette, Marie-Odile Krebs, David Cohen, and all the Engage team for the invitation, and also Thomas Bourgeron for the computer. Thank you. I might be an exception to the rule today, as I am neither a psychiatrist nor a geneticist. I'm just a neurologist. But rest assured, I haven't got the wrong room. I move in circles, in psychiatric circles, because I work at the Vinatier Hospital, which is a psychiatric hospital located in Lyon. I work in a reference center called Genopsy, and my job is to bring a neurogenetic insight into the unusual cases we see there. So, what I would like to do today is to present you two cases to illustrate my job, and also I'd be delighted to share with you some of the many questions I ask myself every day. The first case is about Tarek. I chose it because it illustrates perfectly well the interest of embracing both the genetic and the psychiatric perspectives. Tarek was born in Algeria. He had unremarkable neurodevelopmental milestones. He moved in France at the age of 10. At that moment, he was bilingual. He could read and write, add and subtract. But he had some behavioral issues with poor attentional skills, restlessness, and aggressiveness. A neuropsychological assessment disclosed a mild intellectual deficiency. His mother reported that he was really a dreamer. He used to play all day long with the same red car. And as he grew up, behavioral disorders grew too, often triggered by an incomprehension of social rules and by intolerance to frustration. A workup given at that time was performed, including brain MRI, EEG, metabolic and standard genetic investigations. But nothing came out. As Tarek reached his teenage years, behavioral issues became very significant. For example, one day Tarek was on the subway and he saw a girl he found beautiful. He wanted to pay her a compliment, so he approached her, but went on things badly. So the girl got scared. Seeing that she was stressed, a fellow passenger stepped in to encourage Tarek to back off. But Tarek was not able to read the situation correctly. He probably felt very frustrated and became violent toward the passenger. What started as a compliment ended up in a legal action. From that moment on, his family groaned him, and his mother, thought for medical help again. A new evaluation showed the presence of restricted interests about computers and phones, stereotypies, and the known prosocial interactions. So the psychiatrist evoked the diagnosis of autism spectrum disorder, and Tarek received adapted care and support. But 2 years later, he presented paranoiac ideas and listening attitude, and a new psychiatrist evoked the diagnosis of schizophrenia, and the family was a bit lost between the two diagnoses. The medication gave some motor side effects and were not very efficient on the clinical behavioral features. We met him at Genopsy when he was 24 years. As you can see, clinical assessment revealed strabismus. It showed scoliosis, the presence of a motor apraxia, and Parkinsonian symptoms, probably linked to the medication. As you can see, behavioral assessment is rich and dense. Interestingly, Tarek fulfilled the DSM-5 criteria for both autism spectrum disorder and schizophrenia. We perform an ADIR and an ADOS2 scales. They confirm the presence of abnormal social interactions with the presence of unusual eye contact, limited social responses, and restricted interests. Tarek remained centered on his own preoccupation and couldn't take into account others' point of view. But these features were not significant enough to confirm the autism spectrum disorder. On the other hand, he presented delusions, emotional withdrawal, blunt affects, hallucination, disorientation, unusual thought content, disorganization, mannerism, evocative of schizophrenia. But some of these symptoms, in orange here, might just be linked to the cognitive features, to the intellectual deficiency and the apraxia. We completed the genetic workup, and an array CGH was performed and revealed the presence of duplication on chromosome 15 in the critical region for Prader-Willi and Angelman syndrome. This duplication arose de novo on the maternal chromosome. Interestingly, it is known to be linked to autism and, in a less extent, to schizophrenia. It can, here we had a bit of both in the same patient. At follow-up, motricity was better because we reduced the medication. Tarek had adapted social benefits and care, and 2 years later, his mother came with her little children, because now Tarek has nephews and nieces thanks to the genetic counseling. So, what do we learn from this case? First, it illustrates very well, I think, the gap between the robustness of genetic and psychiatric diagnosis. The genetic diagnosis is etiological, it won't move over time, it tells us what happened. On the other hand, psychiatric diagnosis is symptomatic. It may change over time, given the main features, the main symptoms present the day of the evaluation. Furthermore, some diagnoses may disappear in new DSM versions. We had the case for Asperger, for example. It also shows us that formal diagnosis assessments are not designed for persons with neurogenetic syndrome and may not hold up under more detailed investigation. On these complex cases, an adapted and personalized care should be based on the functional rather than on the categorical diagnosis. Last but not least, it reminds us, because we know that, but it reminds us the overlaps between syndromic and schizophrenia and autism spectrum disorders. I believe that that the more we will use genetic tools in schizophrenia, the more we will see these overlaps, and it might contribute to question the mental disorders classification. So, here's the second story. It's about Sonia. I like that story very much, even if it's a sad one. Technology is moving fast. We can't stop it, we can't ignore it, and we can't continue to work the way we used to do a few years ago, even 2 or 3 years ago, as we will see. But we can choose how and when we use it. Sonia, when we met her, was 8 years old. She was a beautiful girl with a normal development until 5. At the age of 5, she went on holiday with all her family, but these holidays didn't go to plan. She witnessed a huge argument between her mother and her aunt. When she came back, she developed an anxiety, school phobia, and eventually she had to stop school. She became overly attached to her mother, and little by little, step by step, she began to lose speech. Then she wouldn't speak at all. She could still sing some little songs with the right words. At the same time, she lost eye contact and wouldn't engage gaze. Given the extent of the cognitive regression, several workup was performed with multiple hospitalization. It included, among others, brain MRI, electroencephalography, lumbar puncture, extensive metabolic workup, and also an array CGH, MECP2 sequencing, but nothing came out. A psychiatrist, in the absence of any other symptom, came to the rather unsatisfactory conclusion that it might just be in her head. Actually, it took another turn, as we will see now. So, this video has been sent by Sonia's mother 2 months ago. When I met her 1 year ago, symptoms were really milder, but that video is very great because you see the motor feature very well. So you can see on the left that Sonia has a left-hand dystonia and a hyperlordosis linked to a general dystonia. She has also left legs dystonia, so a general dystonia with abnormal choric movement of the mouth. And she won't engage gaze with her mother. Okay, and so we had a general dystonia, cognitive regression, choric movement of the mouth. So we went back to the drawing board and performed another round of investigations, including, among others, a search for Niemann-Pick type C disease, Wilson's disease, neuroacanthocytosis, of course, Huntington's disease, NBIA, and many others. But once again, nothing came out. The nurse couldn't feel all the tubes. She had to stop at one moment because the workup was too big for little Sonia. So a few tubes were put aside. When everything came back normal again, we had the choice to continue the metabolic investigations or to include Sonia in a research protocol with exome sequencing. And 1 month later, with only 1 tube, we had the diagnosis. Unfortunately for Sonia, she suffers from a juvenile Tay-Sachs disease. She has an homozygous pathogenic mutation of XA gene. So, even if we have the satisfaction of having now a robust diagnosis, we can question how efficient we were in obtaining it, because it took 3 years. We had to wait for the motor symptoms to appear to search for that kind of disease. And during these 3 years, Sonia underwent many invasive investigations, many hospitalizations and consultations. False hope and feelings of guilt were given to the family, and the final sanction for the family, but also for the med team, is that now she's too advanced into the disease to be included in a current clinical trial at Rothschild Hospital, because they take children still talking. On the other hand, even if the diagnosis is very sad, the mother say that she had kind of a relief in having a diagnosis. Now she can get prepared. She knows the prognosis. So what do we learn from that case? We shouldn't be afraid to challenge or to continue to look for a diagnosis if the unexpected happens. The other important point is that the fast expansion of genetic tools is and will continue to modify our daily practice. I really believe that it will allow a greater number of diagnoses and faster diagnosis. You remember, I said that I wanted to share my many questions with you. I had to select some of them, but maybe we could discuss that later. I wonder, shall we continue to search for hereditary metabolism disorders separately from other genetic diagnoses when one tool can do both? In that case, if I had the choice, I would have performed it after the first round of metabolic investigation and the array CGH. We would have on 3 years. Talking about the tools, in the field of mental disorders, there is a very hot point. Who should benefit from this tool? There's an urge to define criteria and ethical considerations too. Once we'll have defined these criteria, we'll have to work to make these criteria standard. And we have to work to best optimize the diagnosis process. New algorithms should be defined. And the last question is, how can a genetic diagnosis empower other medical practitioners involved in the patient's care? But I think that other persons such as Maïté Taubert will provide some answers to this question. Thank you very much for your attention.